Good evening, everyone. Welcome to the webinar on Transforming NSCLC Management, Bridging Science and Practice. It gives me great pleasure to invite our Program Director, Dr. Pradeep Ventrapati, Consultant Medical and Hemato-Oncologist, Apollo Cancer Center, Vizag. Over to you, sir.
Thank you so much. Good evening, everyone. I am Dr. Pradeep Ventrapati, Consultant Medical and Hemato-Oncologist at Apollo Cancer Center, Visakhapatnam. So today we will be discussing about the treatment of non-small cell lung cancer. Over the last 10 to 15 years, non-small cell lung cancer treatment has evolved rapidly with the introduction of targeted therapy, immunotherapies, perioperative strategies, redefining outcomes. So the aim of this webinar today will be to bridge cutting-edge science with practical implementation in daily oncology practice. So today we'll have many esteemed speakers discussing different topics, and they will take us through the journey of lung cancer today. And we encourage the audience to post questions in the chat box. So with that, the first speaker will be Dr. Rajani Priya. She is consultant medical oncologist at Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam. And she will be speaking on the topic tracing non-small cell lung cancer footprints from past to present. Over to you, madam.
Thank you, sir. Thank you for the opportunity. So can you please share the slides?
Yes, ma'am.
Yes, ma'am, we will share.
Ma'am, is it visible?
Yeah.
Yes, ma'am. You can say next slides.
Yeah. So a very good evening to one and all. So today I'll be speaking on the evolution of the EGFR TKIs in treatment of patients with EGFR mutant advanced non-small cell lung cancer. So next slide. So this is the outline of the talk. We'll be speaking on the EGFR receptors and signaling, the type of EGFR mutations, and the 3 generation of the EGFR TKIs, which we have in the management of these EGFR mutated non-small cell lung cancer. Next slide, please. So we all know that EGFR signaling drives multiple biological processes leading to cancer growth, which makes it a target for treatment. So this EGFR gene encodes a transmembrane tyrosine kinase receptor, which is expressed in epithelial, mesenchymal, and neurogenic tissues. So signal transduction via EGFR controls cell proliferation and cell maintenance by inhibition of apoptosis. So this EGFR pathways drives many cancers like your pancreatic cancers, glioblastomas, and lung cancers. These EGFR mutations lead to sustained activation of signaling downstream pathways, which leads to cell proliferation and anti-apoptosis. Next slide. So if you can see, binding of the epidermal growth factor with the epidermal growth factor receptor leads to activation of the downstream pathways in normal cells. But in EGFR mutated cases, irrespective of the binding of the epidermal growth factor with the epidermal growth factor receptor, these receptors are constitutively active because of these mutations, leading to a continued activation of the downstream pathway, which are involved in cell proliferation and cell survival. Next slide. So these EGFR mutations can result, which result in sensitivity and resistance to EGFR TKIs. They usually occur as at exons 18 through 21 in non-small cell lung cancers. So these mutations can be either deletions, insertions, or point mutations. So they are usually found in the ATP binding region of the EGFR, particularly the phosphate binding loop, the alpha C helix, and the activation loop. So the common mutations which we see in our practice are the exon 19 deletion and exon 21 mutation, that is the L858R mutation. Next slide. So EGFR mutations account to about 50% of Asian and 10 to 20% of the Caucasian patients. For India, the EGFR positivity rate is 25 to 30%. Next. So of these, as we've already discussed, the most common mutations are the exon 19 and exon 21 mutations. Very rarely we see mutations in exon 18, upfront presentation with the T790M mutations, exon 20 insertions, and other rare mutations. So these common mutations are known to be sensitive to the EGFR TKS. Next. Next slide. So this is the timeline of development of these EGFR TKS. So it was in 2009 when the first EGFR TKA after the IPAS trial has been Gefnib has been approved in management of these advanced non-small cell lung cancer patients in the first line setting. So after 2009, there have been so many EGFR TKIs which have been approved. The first generation TKIs have been compared with the platinum-based chemotherapy and shown to have PFS benefit. Next, we have the second generation TKIs like the afatinib and the dacomitinib. And then the third generation TKIs where we have the osimertinib. And recently, we have the lazertinib, which is also a third generation TKI. Next slide. So this is the IPAS trial in 2009. In 2011 to 13, we have the Lux Lung trials, that is the use of afatinib, which has been compared with platinum-based doublet. In 2015 to 17, we have Aura, that is osimertinib, has been compared in the second line setting. And in 2017, we have the Flora study where osimertinib has been compared with the first generation TKIs in the first line setting. Next slide. So initial results of the Flora has shown only to have a PFS benefit, but in 2019 it has even shown to have an overall survival benefit. So now starting from 2009 we have moved to osimertinib. So initially it was osimertinib alone has been tried, but now we have even data where osimertinib is being combined with chemotherapy and is a standard of care. So it has shown to have PFS and overall survival benefit. So now the treatment options in management of these advanced EGFR mutant non-small cell lung cancer patients include osimertinib with chemotherapy, osimertinib alone, or amivantamab plus lazertinib. Next slide. So these are the various EGFR TKIs which are available in treatment of our patients. So still many of the patients who are not affordable for osimertinib, we go with the first generation TKIs alone or in combination with the chemotherapy. So the first generation TKIs are the Gefnib and the erlotinib. Second generations are the afatinib and the dacomitinib. Third are the osimertinib and lazertinib. So we know that the first generation TKIs are reversible. The second and third are the irreversible binding. The blood-brain penetration is more with the osimertinib, that is, and it has less toxicities because it inhibits more of the mutant EGFR and has less effects on the wild type of EGFR. So we have less side effects with the third generation EGFR, whereas the first generation, and second generation, they have more binding with the mutant and the wild type of EGFR, and we have more side effects because it affects the normal cells as well. Next slide. So that coming to the T790M, osimertinib is the only drug which is active in the T790M mutations. Whereas for the first generation TKs, we require more concentration of the drugs to act against the T790M mutations. Next slide. So these are the ORRs and the PFS of various TKs. If you can see, all the first generation TKIs, initially they were compared with the platinum-based chemotherapies, and the PFS for the first generation TKIs is usually between 9 to 11 months. Next slide. And there is no overall survival benefit with the first generation or the second generation TKI because of the crossover. So these are the second generation drug, that is afatinib and dacomitinib. You can see the median PFS is 11 months to 14 months approximately. And coming to the osimertinib, which is a third generation TKI, the PFS benefit is almost 18 months compared to first generation TKIs where it's only 10 months. And the overall survival benefit is also statistically significant. So osimertinib is the only drug of all the TKIs which are shown to have a survival benefit as well in the Flora trial. Next slide. So you can see the various PFS of the first, second, and third generation, starting with the Gefnib, which is only about 9.5 months, with the osimertinib is almost about 18.9 months. That is almost doubled PFS. Next slide. So these are the various indications where they are approved. So majority of the first and second generation TKs we use in the first line. The doses of the Gefnib is 250 mg erlotinib is 150 mg, afatinib is 40 mg, and dacotinib is 45 mg, and osimertinib is 80 mg per day. So osimertinib is approved in first line and also in the second line. So in first line, alone or in combination with chemotherapy, and in second line, only in patients who have T790M mutation in the second line. Next slide. So this we have already discussed. Osimertinib is approved both in the first line management and also in second line in patients with T790M mutation positive patients. Next slide. So for majority of for uncommon mutations, afatinib has been approved. And for exon 20 insertions, we have to go with either chemotherapy or amivantamab plus chemotherapy. Finally, to conclude, mutations in tyrosine kinase domain of EGFR can drive multiple biological processes leading to cancer growth, making them the ideal targets for treatment. There are 3 generations of TKs with different mechanism of actions and different targets and different efficacies and safety. So all patients with non-small cell lung cancer should be tested for EGFR mutation at diagnosis. So usually the testing which we do is we are sending now NGS panels. Previously we used to do EGFR testing with the RT-PCR. Now we are going with the NGS panel. So recommended first-line treatment for majority of the EGFR mutant non-small cell lung cancers are the first-generation TKs, gefitinib, erlotinib, or second-generation TKs like the afatinib and dacomitinib, and the osimertinib. Osimertinib is the only drug which has shown to have an overall survival benefit in the first-line management of these patients. Thank you.
Thank you, madam. Thank you so much. So definitely, as you said, osimertinib is like a wonder drug. And probably the discovery of EGFR mutations in lung cancer has revolutionized the treatment of many lung cancer patients since it is very common. So what is your takeaway from this? Can you add a line?
So osimertinib obviously is a way to go in management of these advanced EGFR mutated non-small cell lung cancer patients. So usually it depends on like the disease burden, the patient's tolerability and comorbids. If elderly patients, frail patients and disease burden is not very high, then we tend to usually go with the osimertinib alone. But if the patient has high symptomatic burden where you want immediate responses and the patient can tolerate chemotherapy, usually we, especially patients with brain meds and all, we usually try to combine osimertinib with chemotherapy, which is a standard of care.
And
like
do you
lazertinib is still not available in India, so maybe though amivantamab is available, maybe we need to wait.
Yeah. Okay. Nice. Thank you, ma'am. Thank you so much. Any questions can be posted in the chat box. In the meantime, we will go to the next speaker, Dr. Vidya Sagar Dusi, who is a senior consultant medical and hemato-oncologist at Medicare Cancer Institute, Visakhapatnam. He will be speaking on the topic biomarker testing and treatment paradigm in early lung cancer. Over to you.
Good evening, everyone. Can I have my presentation, please?
Sure, sir. Is it visible?
Yeah, I can see that. Can you go to the presentation mode? Yeah, thank you. So good evening once again, everyone. So today I'll be sharing insights on the evolving landscape of biomarker testing in early stage non-small cell lung cancer, particularly how it shapes our treatment decisions today. So let's start. Next slide. So let's start by understanding which biomarker testing is crucial and why biomarker testing is crucial in early stage resectable lung cancer. Next slide, please. So what is the need to test and why should we test? Because roughly two-thirds or 25 to 30% of the patients of non-small cell lung cancer, they are diagnosed at a potentially resectable stage. However, as we can see, despite curative intent surgery and chemotherapy, from stage 1B to stage 3, 45 to 76% of the patients eventually relapse within 5 years. So this highlights the importance of the micrometastatic disease persistence. So I feel this is an area where molecular guided therapy, adjuvant therapy strategies can really make a difference. So understanding tumor biology early through biomarker testing is very essential. Next slide, please. So we all know that EGFR mutations are frequent and consistent across all stages and regions in the world in non-small cell lung cancer patients. around approximately 1/3 of the patients have an EGFR mutation, a meaningful biomarker that helps to inform treatment options. And we can see, especially in 1/3 of the Indian and Asian populations, which is the prevalence is high. And this prevalence does not change significantly across the all the stages of the lung cancer. As you can see, stage 1 has 34 and even stage 4 has 37.5% of prevalence of EGFR. So that is why molecular profiling should not be left out until the patient has a metastatic relapse. So early testing identifies candidates for adjuvant therapy right at the diagnosis. Next slide, please. So let's review what current international guidelines recommend adjuvant regarding testing in the resectable disease. So every major guidelines, as you can see from NCCN, CAP, Canadian, Indian, and the Chinese, they recommend EGFR testing in early stage resectable lung cancer. So NCCN explicitly recommends EGFR mutation testing for all patients with stage 1B to 3A and select people with stage 3B disease also. And however, the Indian and ISLC emphasize the reflex biomarker testing at diagnosis and not after surgery. So this is so despite next slide, please. So as we can see, the mortality still remains a considerable thing in patients with NSCLC across all stages. As the stage increases, the 5-year survival rates drastically come down. So despite these recommendations, the mortality remains substantial across all the stages. Next slide, please. So approximately 30% of the patients with non-small cell lung cancer present with resectable stage 1B to 3A disease at diagnosis, and various factors impact the resectability and operability, like patient-related factors. It could be tumor-related factors or surgery-related factors. So what constitutes 1B to 3A is mentioned in the below. So it is important to understand that a resectable tumor is different from an operable tumor. A resectable tumor is one which has no technical barriers for surgery. However, an operable tumor is something where, after considering all the factors, the surgical excision is deemed to be the most desirable management for that particular patient. Next slide, please. So this slide demonstrates that what are the various characteristics of all the stages of NSCLC and what are the resectability criteria and also the goals of treatment. As we can see from stage 1 to stage 3, including stage 3 resectable and unresectable are mostly treated with curative intent. However, stage 4 patients, it is mostly symptomatic with palliation or with the goal of prolonging the survival. Next slide, please. So as we can see, the 5-year recurrence rates for death in resectable non-small cell lung cancer, as the stage increases from stage 1B to 3, the recurrence rates are increasing. That means despite chemotherapy and surgery, still there is a lot of recurrence and the survival drastically drops down below 40%. So this underscores that surgical resection alone or with chemotherapy alone is not sufficient for these patients, and more adjuvant systemic strategies are to be given and which need molecular guidance. So next slide, please. So whom should we test and which biomarkers matter most in the early stage disease? So, and this is one more slide which shows this is a trial where included 2.21 million patients where they have seen patients who have undergone diagnostic testing coupled with biomarker driven treatment. As we can see, people who have not undergone diagnostic testing have only survived 6 months, the median survival, whereas people who have undergone diagnostic testing and biomarker driven treatment, they have a 3 times more longer survival duration, that is 18 months. Next slide, please. So whom should we test and which biomarkers matter most in the early stage disease? Next slide, please. So earlier when I was a postgraduate, mostly we were taught based on the EGFR, ALK, only ROS were tested, and again we used to correlate clinico-pathologically with the histology. So with the prevalence like EGFR and alterations, ALK alterations, they show stronger association with certain clinical pathological features like non-smokers. However, we should note that the NSCLC, all patients or any patient can have an actionable gene mutation regardless of the clinicopathological features. So next slide, please. So therefore, we should test all the patients who are eligible, like whether irrespective of the clinicopathological features. Next slide, please. So we can see here in resectable stage disease, stage 1B to 3A, and including certain 3B patients, these as per the NCCN guidelines, these people should be tested at diagnosis for EGFR, ALK and PD-L1 status. Whereas for metastatic non-squamous NSCLC, we recommend a comprehensive genomic panel, which includes the 12 genes and the PD-L1. So once we know whom to test and again what to test, we should see how to test. So this can be either tissue specimen or a liquid biopsy specimen. Next slide, please. So NCCN recommends for resectable stage 1B to 3B, both EGFR, ALK and PD-L1 status, and it should be done at diagnosis, not after surgery or something. Next slide. Again, we have like an assumption that mostly PD-L1 and EGFR could be mutually exclusive. But there are retrospective studies which show that 57% of the patients with resectable non-small cell lung cancer disease who tested for EGFR mutation also expressed PD-L1 levels at more than 1%. So even if the patient has a PD-L1 expression of more than 1%, we should also perform or ask for EGFR testing, and simultaneously the vice versa. Next slide, please. So how should we test for this biomarkers in early stage resectable lung cancer? Next slide, please. So various techniques like bronchoscopy, as we know, transthoracic or even thoracentesis, CT-guided thoracentesis biopsy, even surgical post-operative specimens, and liquid biopsy can yield variable specimens for us to establish the diagnosis and also for biomarker testing. However, we should note that in the early stage, liquid biopsy is not yet validated. So it is validated for metastatic NSCLC. Whereas for early stage, the liquid biopsy doesn't hold good. Next slide, please. So for resectable patients, either preoperative biopsy, that is, or even a surgical specimen, both of them provide an opportunity for biomarker testing to decide upon the adjuvant for appropriate adjuvant therapy. And for metastatic disease, it was diagnostic biopsy or even a liquid biopsy. Both can serve as a valid sample or techniques for adequate specimen yield. Next slide, please. So again, multidisciplinary tumor board again helps a lot, especially communication between the interventional radiologist, be it the pulmonologist and pathologist and the medical oncologist. So they all should coordinate accordingly and to see what is the best appropriate way to obtain a specimen and also for the upfront biomarker testing. Next slide, please. So CAP guidelines and the ISLC guidelines recommend that even small the specimens are enough when performed adequately and when sent adequately for sufficient for biomarker testing. So it doesn't mean that we have to have big specimens. So both of the CAP and the ISLC emphasize that even small biopsies can be sufficient. Next slide, please. So again, for resectable disease, again, even when we have tissue, pre-analytical quality is very critical to ensure that there are reliable biomarker results. So this is the method of the obtaining the specimen, the processing of the specimen. I think it would be more appropriate for an oncopathologist to dwell upon these. However, I'll briefly touch upon that. So next slide, please. So as we can see here, 70 to 80% of the test failures, they come from pre-analytical issues like delay in fixation, be it improper formalin use or repeated sectioning can compromise the DNA integrity. So adhering to the CAP protocols and the recommended parameters like fixing the specimen within 1 hour or 6 to 36 hours in 10% buffer formalin, all these things ensure reliable test reliability. And proactive cutting of 10 to 20 unstained slides upon the initial processing also can reduce the tissue exhaustion. Next slide, please. So in parallel, we can also do reflex testing protocols, which can minimize the delays and the missed opportunities. Liquid biopsy, as you can see, for stage 4, it has an excellent yield, like that 73.8%, whereas for early stages like stage 1, that it's only at 12.1%, and therefore it is not clinically validated in the resectable non-small cell lung cancer. Next slide, please. So again, how do we standardize? So as I said, reflex testing is the gold standard, which automatically dramatically reduces the turnaround time. However, the medical oncologists and the surgeons and the pulmonologists can coordinate specimen collection and also can order the test upfront instead of non-reflexive or on-demand non-reflexive testing. Next slide, please. So far, again, as I initially said, MDT is very crucial for patients getting the adequate biomarker testing, which helps to inform the treatment planning. Next slide, please. So far we have covered like why, whom, and how do we test. So summarize what are the key takeaways: that all patients who are diagnosed with NSCLC, even despite adequate resection and adjuvant chemotherapy, because of high risk of recurrence, there is a need for molecular testing based adjuvant treatments, and all patients should be at diagnosis also should be offered biomarker testing, and EGFR testing, especially in the early stages, is recommended by multiple societies. And now we have good data even for adjuvant osimertinib and alectinib as per the trials. So ALK and PD-L1 mutation, because even adjuvant immunotherapy like atezolizumab and pembrolizumab, which we'll be discussing later, I guess. So these are also now recommended options for patients who have upfront, after chemotherapy and surgery. So it is ideal that we should offer biomarker testing for all patients upfront, and multidisciplinary tumor board discussion as to obtain how the for obtaining the specimen and processing of the specimen is also equally important. And yeah, so thank you. So one closing statement I would make is earlier when we were in PG, mostly early stage lung cancer is mostly a surgical disease. We never used to get the patients to see us, but it's no longer a surgical disease. Now it's I think it's probably a molecularly defined entity. So testing means we are making more people, getting cured of the disease in a smarter way. Thank you.
Thank you, sir. Thank you so much. That was a very comprehensive talk. And as you said, no therapy should be started without a proper molecular picture. In the interest of time, we will go ahead with the next talk, which is by Dr. Charan Avala. He is a consultant interventional pulmonologist at Apollo Hospitals, Visakhapatnam, and he will be speaking on the topic setting the invisible with EBUS. Over to you, sir. Sir, you are audible, sir, but you can share your screen. But voice is slightly low.
Yes, it is visible now.
Good evening, everyone. Good evening, everyone. Today, I'm going to discuss about the
Make it full screen, sir. Make it full screen.
Okay, no?
Yes, sir.
As a pulmonologist perspective, EBUS is a non-small cell carcinoma and a lot of trials. And coming to the understanding of NSCLC, a pulmonologist view, first of all,
Slightly the voice is low, sir.
NSCLC accounts for 85% of the all lung cancer. And wait for a minute. Hello.
Yes, yeah, you're audible.
NSCLC is accounting for 80%, 85% of all lung cancer, and especially stage 3 lung, non-small cell carcinoma lung is locally advanced, often sometimes non-resectable cancer, and it needs stage 3, needs a multidisciplinary management approach. And coming to the role of pulmonologist in a diagnosis, staging, biopsy, and follow-up in stage 3 NSCLC cases. And coming to the first part, staging is very essential for clinical decision making and treatment planning in resectable anesthesia. As you people know that involving ipsilateral nodes and contralateral nodes varies the staging of the lung cancer, and to know the extent of the disease and to come the conclusion to like prognosis and treatment protocol. And staging provides a consistent and unambiguous method for clinicians to describe and convey the extent of disease. And stage at diagnosis helps to predict the prognosis, and treatment plans will change according to the stage of the disease, and we can opt like a resectability of the tumor and what type of surgical technique we need for the treatment, and whatever and new adjuvant or newer treatments are required to treat stage 3 patients. And coming to the staging modalities for lung cancer, and previously we used to stage based on the PET CT, CT scan, and MRI scan, which is sensitivity is up to only just 51% sensitivity. And coming to the newer modality techniques, it is navigational bronchoscopy, EBUS, and UES endoscopic ultrasonography, mediastinoscopy, VATS, or thoracotomy. Individually, the sensitivity is above 75% when you combine the procedure, like combining EBUS with UES or combining EBUS with mediastinoscopy, the sensitivity will come up to 85 to 90%. And EBUS and UES will target the lesions in central lesions or mediastinal lymph nodes like upper paratracheal, lower paratracheal, hilar, subcarinal, up to segmental lymph nodes. And coming to the UES, along with these lymph nodes, it can access the adrenal nodes and adrenal metastasis. It can take biopsy. And from celiac lymph nodes, we can approach through UES. And coming to the navigational bronchoscopy, when you don't reach peripheral tumors, and navigational bronchoscopy is the option. What is the navigational bronchoscopy? It is the newer technique, just it's like in a GPS system. It navigates you. It combines the electromagnetic mapping along with your CT imaging. It combines both electromagnetic guidance and CT imaging. It will navigate, and real time it will navigate to which lobe you have to go, which segmental bronchus you have to go. It will navigate you slowly, and it will reach the, it will show you the path for peripheral tumor. And coming to the mediastinoscopy and VATS thoracotomy, these are a little bit highly, little bit invasive procedures when compared with the EBUS and UES. And what is the role of EBUS in lung cancer? First one is nodal staging and lung cancer. And second thing is restaging after neoadjuvant chemotherapy. And third thing is sampling of the perihilar and parenchymal central mass lesions. And it used as the endoscopic ultrasonography to sample the level of 8 and 9 and left adrenal gland. It is endoscopic ultrasonography as I discussed before. And coming to the advantages of ES and EBUS is first thing is when compared with mediastinoscopy and VATS thoracotomy, it is very less invasive when compared with these procedures. And second thing is less morbidity and less complications, and no need of general anesthesia. Just we give monitored anesthesia. And the fourth thing is more number of lymph node stations we can sample, and it can be combined with the transbronchial sampling along with the PPL, peripheral lesions. And coming to the locoregional lymph node staging in patients with non-metastatic NSCLC, first thing is known case of CA lung with CT and PET showing mediastinal lymph nodes and mediastinal lymph nodes positive and mediastinal lymph nodes negative. When lymph nodes are negative in PET or PET CT or CT scan, and the size of the tumor is less than or equal to 3 centimeters, we can go for surgery. There is no issue among these things. And if the nodal metastasis, stage 1 nodal metastasis, and central tumor size more than 3 centimeters, and there is a intense FTG uptake, go for tissue confirmation through EBUS or US or VAX mediastinal. And mediastinal lymph nodes were negative, and go for surgery. And here comes when PET CT mediastinal lymph nodes positive, go for tissue sampling, EBUS or US. And if mediastinal lymph nodes positive for metastasis, then the role of multimodality treatment is come. And if the mediastinal lymph nodes are negative in tissue sampling through US or EBUS, go for mediastinoscopy. If mediastinal lymph nodes are positive, again go for multimodality treatment. If mediastinal lymph nodes are negative, go for surgery. So, what are the types of EBUS? Main thing is previously radial probe EBUS and conventional convex probe EBUS. And radial probe EBUS is mainly for locating the peripheral lesion. Only difference is this is radial probe EBUS is not a real-time procedure. And most commonly used probe is convex probe EBUS, which is real-time. And newly advanced in this EBUS is endobronchial ultrasonography guided cryo-lymph node biopsy. What they will do, they will perforate the bronchus and pass the cryoprobe, and they will extract the tissue. Chunk of tissue will come when compared with linear EBUS. Like we use in linear EBUS, the needle showing mostly we will use based on the EBUS company, we will use 19 gauge needle, 20 or 22 gauge needle. Few companies and compatible for all three sizes of needle, and few companies are compatible only with 22 gauge needle. So when we are doing a case, we have to choose the needle size also. Importance of needle size is very crucial in sampling very small size lymph nodes. And coming to a study, randomized trial in comparing the mediastinoscopy with endosonography for mediastinal lymph node staging lung cancer. And you can see the surgical staging sensitivity is 79% when compared when it comes to the endosonographic staging, sensitivity is 85%. When you compare the negative predictive value between the surgical staging and EBUS or US staging, almost similar. That is 86% surgical staging and 85% in the endoscopy, endobronchial ultrasonography stage. And the endosonographic staging of mediastinal lymph nodes in lung cancer provides higher sensitivity and similar negative predictive value to surgical staging, with no significant difference in the unnecessary thoracotomy. And coming to the EBUS TBNA versus surgical mediastinoscopy for mediastinal lymph node staging, a systemic review and meta-analysis which include 8 studies in qualitative and 5 studies in quantitative analysis. All studies sequentially approaches followed by EBUS TBNA and mediastinoscopy. You can see the sensitivity in EBUS TBNA and mediastinoscopy. In EBUS TBNA, 81% sensitivity, and in mediastinoscopy it is 75% sensitivity. Coming to specific 100%. Coming to the transbronchial, and this is the study showing combining transbronchial and transesophageal 5 needle and EBUS along with EUS 5 needle aspiration using ultrasonography, like it's combining EBUS and EUS in staging of potentially operable lung cancer. In this procedure, in this study, if you take the EBUS TBNA, the sensitivity is 84.4%. When combining EBUS TBNA with EUS TBNA, goes up to 91 above 90%, 91.1. And specificity is both 100%. And main thing is when you are doing alone EBUS, it is 84.4%. When combining EBUS and EUS, it's increasing up to 6%, that is 91%. And coming to a systemic review and meta-analysis, mediastinal node staging performance of combined endobronchial and esophageal endosonography in lung cancer cases. It includes 20 studies involving 2,961 patients, and individual and combining techniques. When you take a EBUS TBNA, endobronchial TBNA, its sensitivity is 79%. If you take the single esophageal ultrasonography aspiration, it is 74%. When you combine the EBUS plus EUS, it is 86%. Specificity is almost similar. And why combining EBUS and EUS is different? Yield is increasing because few lymph nodes you cannot access through EBUS. And in addition to EBUS accessible lymph nodes, EUS can access to retinal glands, celiac lymph nodes, and even liver metastasis also. So if we are increasing the number of accessible sites, definitely the yield will increase and compare with EBUS TBN. And coming to the EBUS TBN and EUS TBN, the sensitivity is 81 to 89%. And when coming to the EUS FNA, it is 83 to 89%. In combining EBUS and EUS technique, it is 86 to 91%. And coming to the ROSE, what is ROSE? Is rapid on-site evaluation. It needs equipment with few basic strains along with a good expert pathologist. And current evidence shows that conflicting evidence regarding use of ROSE. Currently, various guidelines suggest using ROSE during EBUS TBN were available. And if you, what is the main purpose of ROSE while doing EBUS or EUS is, first thing is sample adequacy. Whether we are in lymph node or some other area or any mediational fat, first thing we are taking the sample, even though it is a real-time procedure, we have to confirm the sampling, either it is from lymph node or from somewhere else. So first thing, we have to check the adequacy of the sample. Second thing is rapid diagnosis. And if you take the ROSE, there is no change in the diagnostic yield. And overall procedure time or complication rates, there will be no change. But only thing is, if the sample is adequate and if the sample is showing some metastasis, then we can cut down the number of needle passes through that particular lymph node. And it minimizes the bleeding complication. Coming to the pre-chemoradiation therapy and the role of the pulmonologist in treating NSCLC stage 3. First thing is, what is pulmonologist work is, first thing, it is a already known case of malignancy. So, first thing, pulmonologist should discuss with medical oncologist what medical oncologist need, what pathologist need, just to confirm the metastasis, or you need any genome NGS sampling, or you need histopathology sampling. And second thing is, what test is recommended for molecular testing or EGFR, all like that, or we need to coordinate with oncologist, pathologist, and radiologist, and prepare the patient for curative intent of chemoradiation therapy. And why the LAURA trial matters? Many patients relapse after chemoradiation therapy in stage 3 NSCLC. If the patient is EGFR mutation positive, patient derive limited benefit from CRT alone. LAURA aim to improve the performance, prognosis, PFS using osimertinib post CRT. And what is the benefit of osimertinib is, it is a brain penetrant, good CNS penetration. It works good with CNS metastasis, and is a third generation EGFR tyrosine kinase inhibitor. And population involved in NSC LAURA trial is unresectable stage 3 EGFR mutation positive NSCLC post CRT. It randomized trial 2:1 osimertinib with placebo, and primary endpoint of the study is progression-free survival, and secondary endpoint is overall survival, CNS progression, and quality of life. And the key results from LAURA trial is median PFS is 39 months nearly versus 5.6 months in placebo, and 74% reduction in risk of disease progression or death, and favorable CNS protection profile, and adverse events are manageable and consistent with known profile. And how pulmonologists can integrate this and push for EBUS in all suspected cases of N2 and N3 cases NSCLC, ensure molecular proliferating upfront, and collaborate to identify EGFR mutation cases early, and counsel the patient on evolving therapeutic landscape. And takeaway points is, EBUS is vital for diagnosis, staging, and molecular testing. Pulmonologists drive early decision in stage 3 NSCLC. LAURA trial shows osimertinib improves PFS in post chemoradiation therapy, and molecular testing must be a routine part of workup. Thank you.
Thank you so much, sir. That was an excellent talk, very informative. So if I may ask you a question,
Yeah.
We know that you have done numerous EBUS procedures in your career.
Yeah.
So what is one of the biggest challenges you faced during performing this procedure?
Main thing is, first of all, we need coordination with pathologist and primary consultant like medical oncologist for what they need sample, because uh, have most things happen is miscommunication between the consultant. First thing we need to get proper information, because are you suspecting metastasis or any infection like tuberculosis, or just secondary malignancy. So second thing is we need good pathologist on our bedside. And third thing is patient counseling. Patient counseling is very difficult nowadays for procedures.
Thank you, sir. Thank you so much. So with this, in the interest of time, we'll go ahead with the next talk, which is by Dr. Srikanth Dikkala. So he's a senior consultant medical oncologist at HCG Cancer Center, Visakhapatnam. So he will be speaking on the topic, transforming the unresectable stage 3 non-small cell lung cancer landscape from Pacific to LAURA. Over to you, sir.
Thank you, Dr. Pradeep. So is someone sharing the slides or? So are my slides visible?
Yes,
Sir, I have shared your slides, so you can just say next. Sir.
Okay, fine. Good evening, everyone. This is Dr. Srikanth. So today I'm going to discuss in brief about transforming the unresectable stage 3 NSCLC landscape from Pacific to LAURA. Next slide. Go to the previous slide, please. Yeah, so stage 3 is a highly heterogeneous based on the tumor size, node, and other tissue involvement. Only selected patients in this stage will be candidates for resection, mostly in stage 3A. Very few patients are resectable in stage 3B. So all cases should be assessed by MDT. So in the UK audit data from 2017 were on treatment of stage 3. So only less than 22% of patients with stage 3A and less than 5% of those with stage 3B have received surgery as part of the treatment. Next slide. So if you see the overall survival by pathological stage, like it's going almost, it's becoming half. Like from stage 3, it is median OS is 41 months, and it's going to 22 in 3B and 11 in only 11 months in 3C. So this indicates how heterogeneous is the disease. So multidisciplinary assessment is very crucial in managing this unresectable stage 3. Next slide. So the various factors we need to consider are firstly patient factors, where the performance status of the patient and how are his comorbidities, pulmonary function, cardiac function, and what is his preference, most importantly. And certain tumor factors like what is the bulk of the nodal disease, which stations are involved, is it technically resectable, and can a curative dose of radiation be delivered? So we need to consider all these factors before coming up with the treatment plan. Next slide. Next slide. So there is an Asian consensus for biomarker testing recommendations for unresectable NSCLC. So it recommends PDL1 and EGFR testing for all patients. So based on the results of these biomarkers, we need to plan our treatment accordingly. Next slide. So the NCCN guidelines, as we can see, so when we plan a concurrent chemoradiation, there are various chemotherapy regimens, platinum combination doublets, and also there is consolidation therapy where the patient with his EGFR positive, we go for osimertinib until disease progression, and also those who are EGFR negative, we have data for durvalumab for a total duration of 1 year. Next slide. Next slide. So the real world scenario is different to what we see in the literature. So the completion rate of concurrent versus sequential was studied in the Proclaim study, where they can see the both chemo and radiation were completed in concurrent arm of 90% in 63% of the patients, where when there is a sequential treatment, only 46% of the patients were able to complete the sequential protocol. Next slide. So among the consolidation therapy, there are various trials where they have seen consolidation with different chemotherapy regimens like docetaxel or combination cisplatin doxy and pembro versus eto. So, and also there is a consolidation trial where they have tried to escalate the dose of the radiation along with chemotherapy. If you see the hazard ratio in all these trials, it is not very great. So next slide. Next slide. So how to improve these outcomes in patients with unresectable stage 3 NSCLC based on the PACIFIC trial. Next slide. So in the PACIFIC trial, stage 3 locally advanced unresectable NSCLC patients who have not progressed following definitive platinum-based chemoradiotherapy were randomized into having durvalumab maintenance for a total duration of 12 months versus placebo. The main primary endpoints being PFS and OS, and key secondary endpoints being ORR and duration of response, safety and tolerability. Next slide. So if you see the median OS, so it is 47.5 with durvalumab arm and it versus 29.1 in the placebo arm with hazard ratio of 0.72, which is very significant considering this particular niche patients where there are limited treatment options. Next slide. So durvalumab has demonstrated overall survival of 42.9% at OS, which is quite good considering for a patient who has driver mutation negative. Next slide. So this benefit has been seen in across all the pre-specified groups. If you can see that the benefit is more with those who are having PDL1 of more than 25%, but it is still significant in those who are having less than that also. Next slide. So the PFS, if you see, it is 16.5 months, 16.9 months with the durvalumab arm, and with placebo it is only 5.6. This is also very significant. Next slide. So it showed the PFS, so sustained and durable PFS of 33.51% benefit at the 5 years with the hazard ratio of 0.55, which is quite good. Next slide. So this PFS is seen across all the pre-specified groups. And next slide. So pneumonitis. So these patients who receive immunotherapy, we also have a concern about those who are receiving concurrent chemoradiation, where radiation pneumonitis is also documented. But if you see the incidence, any grade of pneumonitis is not too much varying from those with placebo versus durvalumab arm. It is 34% with durva and 25% with placebo arm. Next slide. So this is one thing which we need to consider where. So what is the incidence of pneumonitis? Those in whom this maintenance was started within less than 2 weeks of completion of CTRT. So, and those who have started after 2 weeks of CTRT. So there is no such difference. So you can start the therapy with durvalumab immediately after completion of the CTRT. Next slide. Next slide. So the PFS and OS in PACIFIC study population, those are having EGFR mutation, as we can see, it did not show clear OS or PFS benefit. So at the baseline, doing both PDL1 and EGFR mutation status is very crucial in planning the treatment for unresectable NSCLC. Next slide. So outcomes on patients with those who are EGFR mutant in stage 3 NSCLC based on the LAURA trial data. Next slide. So in the LAURA trial, it is a phase 3 double-blind randomized trial where locally advanced unresectable stage 3 EGFR mutant patients who are not progressed following definitive CTRT were randomized to receive osimertinib versus placebo. The treatment duration, so the primary endpoints being PFS and also PFS assessed by BACR and also by investigator. Secondary endpoints being overall survival and CNS, PFS, and safety. Next slide. So the baseline characters are pretty much comparable. Next slide. Next slide. So look at these curves. Like there is very early separation of both the curves with the 2-year PFS of 65% with osimertinib with a stunning hazard ratio of 0.16 as per BICR. The same is with the investigator assessed also. Next slide. Yeah, so even here, like even in the investigator assessed, it is also the hazard ratio is 0.19, where the median PFS is almost 39 months with osimertinib. Next slide. Yeah, so this thing which we already know, this benefit is across all the different subgroups. And as we all know, those who are having exon 19 deletion, the benefit is more compared to L858R. Next slide. Next slide. So if you see this forest plot, as we can see, the objective response rate is 57 with osimertinib. And also the main thing I want to focus here is the duration of response. If you can see, it is almost 3 years, like it is 36.9 months with osimertinib, which is quite significant. Next slide. Next slide. So this is one thing where the incidence of new lesions. So osimertinib has shown to reduce the incidence of brain lesions and also lung lesions compared to the placebo. So this is one significant molecule which is showing activity even in the brain. Next slide. This is reflecting in the survival benefits across all the primary and co-primary endpoints. Next slide. Next slide. So any grade adverse events leading to discontinuation is only 13% with osimertinib balm. So considering we are giving this drug for a long duration, so those who are requiring even dose reduction or interruption is also very less. So next slide. Next. Next. So radiation pneumonitis is not pretty much different when we compare both the arms. So obviously the incidence is a little bit high with osimertinib arm, but it is not too significant. Rest of all the TK induced side effects like diarrhea and rash are common, and mostly those are of low grade and pretty much manageable. Next slide. Next. Next. So what is the rationale for this indefinite dosing? If you can see the older trials where they have used adjuvant geftinib or adjuvant erlotinib in the adjuvant and select trials, so that all these both the curves, they begin to converge by the end of maybe at the 36 months. But if you see in the other trial where even after the 36 months, even though there is a sharp drop, the curves are still pretty much separated. So probably this is the rationale for indefinite dose. So I would like to know how it is from how my other speakers and panelists are experienced, like how long are they doing and how is their response. I would like to know how is regarding this particular. Next slide. Next. So the time to onset of radiation pneumonitis, it is pretty much same with both the arms. So most of the patients, the grade is very minimal. So most of the patients, they tolerated very well, and the severe grade pneumonitis is seen in very few patients. The onset is also similar, comparable between the both arms. Next slide. So again, coming to the guidelines, so based on these two data, as we can see, the consolidation therapy for patients, those are easier for mutant osimertinib is given until disease progression is category 1 recommendation, and those who are easier for negative durvalumab is indicated for up to 12 months. Next slide. So to conclude, based on the results of specific trial, durvalumab consolidation after CTRT became a global standard of care in unresectable stage 3 NSCLC. So there is significant and durable OS benefit. The median OS is 47 months with durvalumab versus placebo. The 3-year OS rate is 57% versus 43. 5-year OS rate is 43 versus 33%. However, the EGFR mutant patients derived limited benefit from immunotherapy, highlighting the unmet need which paved the way for LAURA trial. Next slide. So to conclude, EGFR mutation testing is critical in stage 3 to ensure optimal outcomes in patients with EGFR mutant NSCLC. Until recently, no approved target therapy was available. But now with the results of LAURA trial, osimertinib is now approved and has become the new standard of care. So osimertinib demonstrates statistically significant and clinical meaningful PFS benefit compared to placebo. The median PFS is up to 40 months with osimertinib versus 5.6 months with hazard ratio of 0.16. I don't recollect many trials which have such a good hazard ratio. So while the overall survival showed positive trend, mature data is awaited. Safety profile is pretty much manageable. Next slide. Next slide. Yeah, thank you.
Thank you so much, sir. So that is a very extensive talk covering everything. And I agree with you, sir, where you said, the indefinite dosing is probably important. That is probably what is happening in the ADAURA also. So because there are late relapses. So I think indefinite dosing is very, very important, especially in a locally advanced setting. Would you like to add any takeaway message, sir?
So previously we have been waiting for this particular segment where after unresectable NSCLC, after definitive CTRT, there was a definitely huge vacuum. So we have durvalumab with good data, but a lot of other molecules have tried in this setting, but most of the trials were negative. Now with very mature data of osimertinib in EGFR mutant patients, we are also pretty comfortable. So either ways, we have good options now. So to go either ways. So I feel it will benefit most of our patients.
Sure, sir. Thank you, sir. Thank you so much. So with this, we move on to the next session, which is our panel discussion today. So for the panel discussion, we'll be discussing about the topic role of immunotherapy in early setting. So we want to invite our panelists today. So Dr. Lakshmi Dipti madam, Dr. Venkatesh sir, Dr. Kishore Kumar Kota sir, Dr. Paidi Venkateswara sir, Dr. Srikanth Dikkala sir, and Dr. Rajani Priya madam, Dr. Vidya Sagar Dusi sir, and Dr. Ravi Charan sir. So I hope everybody is present.
Yes, sir.
So I'll share my screen. So is my screen visible?
Yes, sir.
Okay. So as we have discussed about the evolution of lung cancer therapy, so this is we are going to explore another aspect of lung cancer treatment. So we know that the early stages of lung cancer are now being increasingly diagnosed, and this has further been amplified after the COVID pandemic, probably because of increased use of HRCTs. And we now see that out of all lung cancers, almost 30% of the patients are resectable. But unlike breast cancer, in lung cancer, even after surgery, there are very high recurrence rates. And with the addition of chemo, you can see here in the slide that even after in a stage 1B disease, the 5-year survival is still 68%, means 30% of the patients are recurring. And in a stage 3 disease, you can see that almost 80% of recurrence are present. So there was addition of chemotherapy in the adjuvant setting and also in the neoadjuvant setting, but the benefit was at best modest, almost around 5% only. And and we have seen that immunotherapy has shown increased efficacy in advanced non-small cell lung cancer. So what we have done is we have tried to integrate in the early NSCLC setting also. So the goal here in early NSCLC is to prevent the recurrence and increase the cure rates. And it is more feasible because the burden is also low. So in the adjuvant setting, when we are planning therapy, we understand that it has a better safety profile, and also post surgery there is a decrease in immunity. It is an immunosuppressive environment. So by giving adjuvant immunotherapy, we are restoring the anti-tumor immune activity, thereby leading to the elimination of micrometastasis. In the neoadjuvant setting, because already there is a lot of tumor, by giving immunotherapy, we are eliciting a very good anti-tumor immune response. And also we are able to see how the tumor is responding also by giving it in the neoadjuvant setting. So with that, we understand when we are trying to manage resectable NSCLC, we need a multidisciplinary setup, and it should include a pathologist, radiation oncologist, medical oncologist, a pulmonologist, and a thoracic surgeon. And it is very important to establish a diagnosis and evaluate the patient before treatment clearly to establish the stage of disease. So for that, we do a PET CT, preferably an MRI brain with contrast and mediastinal lymph node evaluation. So we know that surgery is the standard of care, but now the question here is, where should we integrate this immunotherapy and chemotherapy? Should we do it in the neoadjuvant, adjuvant, or in the perioperative setting? So we have multiple trials evaluating this aspect. So one is the neoadjuvant. So we have one trial in the neoadjuvant setting, which is the Checkmate 816, where nivolumab was combined with chemotherapy for 3 cycles, and then surgery was done. We have 3 trials in the adjuvant setting, where the immunotherapy was given only in the adjuvant setting. You can see at the bottom of the slide, the keynote 091, where they used pembrolizumab and then atezolizumab and durvalumab. And then we have 5 trials which have evaluated it in the perioperative setting. So now let us move on to the case discussion. So it is here we have a 60-year-old lady, an ex-smoker, no comorbidities, and she was incidentally detected with a lung lesion on chest X-ray done for a cataract surgery in February 2022. On the CT, so CT scan was done, which showed a right lower lobe lung mass of 3.4 into 2.2 centimeters with bilateral emphysema and enlarged right hilar lymph node. So my first question to Dr. Lakshmi Dipti. So would you do an NGS plus PDL1 in this patient? What is your approach?
I would prefer to go with an NGS and PDL1, sir.
Okay. Yeah. Okay. Sorry.
Yes,
NGS
sir.
and PDL1 both. So
NGS
what would
and
you?
PDL1, yes, sir.
Yeah. So what would you want to look in the NGS? Any specific mutation, or a comprehensive panel, broad gene panel?
I would. My main target, my main goal was to see for the EGFR, ALK, and the ROS, where we are having available targeted therapies, sir. Other than that, other inhibitors, though they are available, we are not generally using because of the cost and availability, sir. My main focus is on these 3 and the PDL1, sir.
Nice. So my next question to Dr. Venkatesh. So which strategies do you use for biomarker testing in the absence of an adequate biopsy, or if the patient is unable to undergo a biopsy?
So for the first question, the absence of adequate biopsy, definitely I'll explore all the possible measures to get a repeat biopsy, be it interventional EBUS guided. If it is a resectable upfront, not a metastatic case, then we'll go for a repeat biopsy of the lung mass, or if it is a nodal mass, whatever is feasible, EBUS guided or whatever. But if it is a metastatic, then anywhere as a feasible metastatic site. But coming to this case, if patient is not able to undergo repeat biopsy, but early stage, I don't think it should be like a repeat biopsy is not feasible. Early stage, unless it is very small, where maybe surgery can be gone up, right? Otherwise, liquid biopsy in a metastatic stages. This is
metastatic setting. So you won't go for a liquid biopsy in the early setting, right?
Not much beneficial, as already Dr. Vidya Sagar also shown the data. So that's it.
Yeah, I agree. So my next question to Dr. Kishore sir, would you do a brain scan for this patient, or a CT or a PET scan is enough?
Yeah, yes, I will do a brain scan for all resectable cases. Make sure there are no any brain metastasis. Even though PET was negative, I try to do an MRI brain to exclude any brain mets or to exclude any meningeal enhancement. Those things I will likely to incorporate a MRI brain in all resectable lung cases, especially in these locally advanced cases.
Okay, sir. Okay, nice, sir. Nice. And what about ctDNA, sir? Do you do ctDNA also?
Routinely, I am not doing, but yes, there are some trials like in Adura, they have done ctDNA at baseline, and they have followed up the ctDNA after surgery and before starting Usmatinib. But routinely, I am not doing. But if everything is available, I try to do.
Okay, sir. Okay. Nice, sir. Nice. Thank you, sir. So we'll go ahead with the case. So an MRI brain was done. There are no metastasis. PET CT was done, where a right lower lobe mass was seen and a right hilar lymph node was present. And 6-minute walk test was done, which was 580 meters with an SP out of 97% after the walk. PFT was also done, where the FE1 was 73% of the predicted value and DLC was 46%. So histopathology and molecular analysis was done for the patient. The biopsy showed adenocarcinoma, TTF1 was positive, EGFR mutation alpha fusion was negative, PDL1 was 40%. The mediational staging with the EBUS TBNA was done, and station 11R lymph node for malignancy was positive for malignancy. Level 2 lymph nodes were negative, and the rest of the workup was normal. So with a 3.5 centimeters mass and a hilar lymph node, so this patient will be falling under stage 2. So my next question to Dr. Ravi sir. Sir, are you there? Okay, fine. So my next question to Dr. Venkateswara sir. Sir, what are the treatment options you would consider for this patient who is a stage 2, which is a stage 2 disease, stage 2B?
So these are the right candidates we should discuss in tumor board. We will discuss with our surgeons. Most likely, I would be pushing for a neoadjuvant chemoimmunotherapy for this group of patients, since we have adequate data for neoadjuvant IO for stage 2 and 3 who are resectable.
Okay, sir. Okay. So you will plan for a neoadjuvant, sir, or you will plan for a perioperative approach upfront, sir? Or like what?
Perioperative. Perioperative is what I would choose.
Okay, sir. Okay. Okay. So the next question to Dr. Srikanth, sir. Sir, what are your primary clinical goals and or objectives regarding the use of periop chemoimmuno, as Dr. Venkateswara sir has mentioned, in these patients with early stage NSCLC? Dr. Srikanth, sir? Dr. Rajani Priya madam can take this question if she's there.
Yeah.
So, ma'am, what will be your primary clinical goals or objectives here when you are planning for periop chemoimmuno?
So, like the endpoints for any of the perioperative or the neoadjuvant trials, especially for the neoadjuvant setting, we would like to look for the PCR rates or the major pathological responses. So, which are surrogate markers for overall survival and event-free survivals. So, definitely in this patient, because she's positive, hilar lymph node positive, we would go for neoadjuvant chemoimmunotherapy only. But one question I would like to ask is like, if we are doing NGS, the report will be delayed, right? At the most, will be at least the turnaround time will be at least 2 to 3 weeks.
Yeah.
So you're doing NGS for your patients, or you're doing IHC for ALK and RT-PCR, EGF, which where the TAT is a bit less. So how do you do? And you're
Yeah.
starting all your patients with chemoimmunotherapy, or you're starting with just chemotherapy for the first cycle, and based on the NGS report, if they're EGF or ALK negative, then you're adding immunotherapy.
Yeah, anyone wants to take that question?
So ideally, we should be doing PCR and IHC so that we get a report by earliest within a week. And I think we should wait for the results before starting therapy. And ideally, we should go for chemo plus IO combinations rather
Yeah,
than
but we're asking
starting
the patient
chemotherapy
to
for the
wait for
first
2
cycle.
weeks.
It's an
Maybe
early stage cancer, right? No,
maybe the early stage, like after a cancer diagnosis.
We should try to get the report by 1 week. If you are doing a PCR and if you are
Yeah,
doing an
yeah,
IHC,
PCR
definitely we'll get it by 1
Yeah,
week.
yeah, yeah.
We should
yes.
not do an NGS in this setting, because
That's
from
okay.
the other markers we are not going to derive
Not going to
any
add
benefit
anything.
from it. Yes.
Yeah.
So PDL1, EGFR and ALK would suffice in earlier stage setting.
Yes. So I
Very
think
good.
these 3 should be done. Yes. So we can get the results earlier and we can plan a treatment.
Yes, sir, I agree.
And so in our this primary goals is only the PCR rates or the MPR rates which I'm going to look for. And PDL1 score, maybe that will not impact my decision because we have data irrespective of the PDL1 expression in the neoadjuvant and the perioperative setting, especially in the neoadjuvant setting, there are good responses even in PDL1 negative patients.
Yeah.
Maybe we
And,
can just prognosticate the patient that if the PDL1 score is high, he's going to do well with the immunotherapy component as well.
Correct, madam. Yes, PD-L1 score is not going to definitely impact our decision. It will, but it will give us more information. Probably it will set the expectations for the patient about how he is going to respond. Probably.
Okay. So if the patient is EGFR positive in this, so what will you do? Node positive. You'll give chemotherapy.
Madam, Pradeep is moderator.
Okay, but yeah, so probably definitely I
It's
will
just
think.
discussion, Venki.
Yeah. So probably we'll go for so if it is a resectable patient, we'll go for chemotherapy. I mean surgery directly, because we are looking at a resectable disease, which is a stage 2B disease here. So which is upfront resectable. We will not preferably not think about giving neoadjuvant here. Yeah.
Okay, sir.
And so how do you choose which IO to use? So now, because as we have seen in the previous slide, we have different immunotherapy options which have shown benefit. So how do you choose which IO to use, Dr. Vidya Sagar?
So I think basically almost all the drugs like nivolumab, there is data for nivolumab, pembrolizumab, durvalumab. I think based on the convenience of the physician, because the PATCR rates are not that different, and the event-free survival rate hazard ratios are also more or less same. So 48 to 56% or 60% around, and PATCR is also 17 to 24 in all the trials. So again, it depends. Again, only nivolumab has as per now, for if they are using in the neoadjuvant setting, there is no need for maintenance. You just give along with chemo and stop and do a surgery. So if because of the few cycles, yes, I may prefer nivolumab, but yeah, depends.
Yes. So there is a recent analysis also, sir, where they have compared. So there is this trial where periop nivolumab was used, Checkmate 7070, and they compared it with Checkmate 816. So they did a propensity scoring matching, and in that they found that periop IO was better in many patients, though that cross trial comparison may not be right, but they found that periop nivo may be better than only neoadjuvant and evo. We'll come into that discussion also afterwards. So the last question: which platinum agent do you prefer for chemotherapy? Like, is it cisplatin or carboplatin? What do you all prefer? Everybody can answer.
Mine would be 2/3 carbo and maybe 1/3 very fit patients cisplatin, sir.
Okay, 2/3 carbo. Okay. Dr. Lakshmi Deepti, madam. Dr. Lakshmi.
Yes, sir. Yes, sir. Yes, sir. Sir, my preference is more towards carbo, sir.
Okay. Okay.
My
Deepti, madam.
cisplatin. If patient
Cisplatin.
cannot tolerate cisplatin, maybe I'll go for carboplatin. But if you can see in this agent study, not majority of them received carboplatin rather than the cisplatin. Even that I was wondering why. But we know that in adjuvant setting, we have robust data to say that cisplatin is a standard of care. And so even that comes to the neoadjuvant setting as well. We have more data with cisplatin besides. So I'm not comfortable replacing my cisplatin, even though we are adding immunotherapy.
Curative setting, because even
Yes.
meta-analysis showed benefit with cisplatin, right?
Cisplatin.
Only
So,
correct. Yeah. So but I think most of us give carboplatin probably. And as you said, even now all the periop immunotherapy trials, they have been including carboplatin as
carboplatin, yes.
So coming to this Asian study where periop chemoimmunotherapy was explored. So the inclusion criteria was resectable NSCLC, where they included 2A and 3B, 3B only with N2 disease. And so a lobectomy sleeve resection was done as planned surgery. And if it is a planned pneumonectomy, it was actually excluded. And PDL1 status should have been present before, and they did not allow any EGFR and ALK mutations in this study. So the patients were randomized to durvalumab plus platinum-based chemo or placebo plus platinum-based chemo, and then a surgery was done. And durvalumab was continued for 12 months. So here we can see that all the baseline characteristics are well matched between both the groups, and you can see that here almost majority of the patients had stage 3 disease. And even if you look at the PDL1 expression, 33% of them were less than 1%. And as madam has said, 72% were receiving carboplatin here. And even if you look at the TNM classification, almost 50% of the patients were having N2 disease to begin with. So here you can understand that it is mainly stage 2A, 3B, per patient profile, which include 46.2% squamous population, and he also T4 patients were 26.5%, and the primary endpoints were PCR and EFS. So the patient disposition and treatment summary can be seen here. So they were randomized between 2019 and 22, and that the first planned interim analysis of EFS. You can see that there was a benefit in the EFS favoring the durvalumab arm, 60% versus 47.9%. Also, the benefit was maintained across all predefined subgroups, whether it was squamous or non-squamous, stage, N2 disease, either single or multi-station, or even PDL1 expression less than 1% also. So also, if you look at the complete response rates, that is pathological complete response rates, in the immunotherapy arm, it was 17% versus 4% in the placebo arm. And even the major pathological response rate was also very high, 33% versus 12.3%. The 3-year PFS was 60 versus 47. The OS, it is still immature, but it is not reached versus 53.2. And the grade 3 for adverse events were 42% in this study. So now we continue with the case. So the patient has received 4 cycles of NSCT with IO, and the response assessment was done after a 4th cycle with the PET CT, and it showed partial response, which you can see here. And so the next question: would you consider reassessment for the patients after 4 cycles of chemoimmunotherapy? Dr. Venkatesh?
Yes, sir, definitely. So we do, before proceeding for surgery, we need to get a response scan to check whether it is progressed or whether it has responded or not. And yeah, goals of the assessment should be to achieve maximal resection, preferably as much as possible to achieve R0 resection. That will be the goals of resection. So, and coming to constant case, we definitely don't response scan usually will be PET scan or whatever is done prior.
So any other point which you would want to look for when you are reassessing the patient?
For the progression side, if anything, and whether the response has been achieved or not, that is the main considered factors which we do.
So what they say is they also want to look for any development of pneumonitis, because that may be a contraindication for anesthesia.
Yeah.
But sometimes the patient may not be fit for further therapy.
Yeah.
So okay, fine. So you have answered the rest of the questions also. So we'll go ahead with the discussion. So this is the planned treatment and surgery summary in this study. So you can see here that only 80% of the patients who were randomized had underwent surgery, both in the durvalumab arm and the placebo arm. And of that, you can see here that 6 and 7% of the patients had progressive disease. That is why they haven't undergone surgery. So this is one of the negative points of giving neoadjuvant therapy. That is one of the small criticisms which comes across. So now going into the discussion. So as they have shown in the trial that there are around 20.4%, 20% attrition rate. So this is what you see in your clinical practice also, Dr. Kishore?
Yeah, exactly not. Why? Because in last 4-5 years, I have given 3 patients for NSCT, and those 3 patients went for surgery. But in trials, as the number increases, maybe the attrition rate may increases. That's why it may not be an exactly same. But by God's grace, as you rightly said, until now I haven't experienced progression on treatment. But yes, there is a chance of progression. We should keep in mind, and we should inform to the patient the chance of progression is roughly comes around 5%. And 20% of the people not underwent surgery, not all because of the progression. Only if you look into the both placebo and the immunotherapy, both arms, roughly around 5 to 6% only because of progression. The remaining all maybe because of side effects, or maybe very less percent on the side effects and patient choice and some experience in death and those things only. But because of progression, only 5 to 6%.
Okay, fine. And what is your preferred surgery in early lung cancer patients, Dr. Venkateswara sir?
I wouldn't prefer any surgery. My surgeons will decide what they want to do. Usually it would be a
Good answer, sir. So
it's
I
the
think we'll
discussion
skip the
between
next
patient and
question.
the surgeon.
Yes, we'll skip the next question also then. Fine, we'll not go into surgical details. So will you, so now, sir, so please answer this question. Will you treat patients not achieving PATCR with further adjuvant IO therapy, or will you treat them?
I would continue adjuvant IO therapy, irrespective of whether they achieve PCR or not.
Okay, correct. Okay, fine. And any particular reason, sir, why you would want to do so?
Just looking at the trial details, the perioperative trials which they have used, they have continued it. So I exactly don't know the subsets where patients who did not achieve PCR, whether there was benefit of adjuvant IO, but overall, if you look at the recommendations and guidelines, it is recommended to continue it.
So
I
actually,
would like to know if there is any such analysis in these perioperative trials.
yes, sir. So, there is only one analysis, sir, and that, as we have discussed, so that was done only for nivolumab. So there, what they have seen is that patients who have achieved PATCR, for them probably whether you give adjuvant IO or no IO, there was not much difference. And also patients who had PDL1, positive more than 1%. For them also probably, whether you give adjuvant nivo or not, there was not much difference. But whether we should take this data seriously or not, I'm not sure, but that is what the data says, because it's not a head-on comparison.
Okay.
So now what about N2 disease, Dr. Rajani Priya? Will your selection differ if the treatment selection differ if the patient is N2 positive? How will you treat them?
Yeah. So as you have mentioned previously in your slides that even for N2 patients, they benefited with this neoadjuvant chemo strategy. So usually multi-station N2 we know that they do badly, and only for single station N2 we can go with the curative intent. But with the advent of these neoadjuvant or the perioperative strategies, maybe we can give a try of this chemoimmunotherapy because we have good PCRs and MPR in these patients with good DFS benefits. So maybe we can try.
Oh, yeah. Thank you, madam. So we'll go ahead with the case. So
If I may ask, sorry to
just
interrupt.
please.
Sorry to interrupt, Pradeep. I just want to know the thoughts on what about adjuvant radiation, like in this setting, if this is N2.
N2 disease, the Langa trial.
Yeah.
Okay.
So considering that we are given neoadjuvant chemotherapy and that is N2 now. So any thoughts on about adjuvant radiation?
Yeah. So after you are saying after the surgery.
Yeah.
So even in that, I think it is a negative study, if I'm not wrong, right?
Only for positive margins.
Yeah, post-op radiation is
after
only for
surgery.
surgical margins positive.
Only for
Not for
positive
N2.
margins, not for N2 disease. So that for N2 it was negative, I think, in that study, in the Langa trial.
Yes, sir.
Yes.
Okay. Yeah. Thank you. So now so the surgery was done. Right lower lobectomy was done with mediastinoscopy, and the histopathology was a complete pathologic response T0 N0, and then the patient was given 12 cycles of adjuvant immunotherapy until August 2023, and there is no recurrence until last month. So now we have two more trials, similar trials in the same setting, which is the Checkmate 7070 and the Keynote 671. This question is for everyone. Which patients do you think may benefit most from treatment, with perioperative immunotherapy? Is there any particular subset of patients where you would want to say, yes, this is the patient I would definitely want to give periop immunotherapy? Dr. Kishore?
Yeah, sorry, just please repeat the question. I just missed the.
So now we have multiple types of patients, right? So is there any particular factor or particular feature in the patient where you would want to definitely treat it with perioperative immunotherapy?
Yeah.
Or which patient do you think will benefit most from perioperative immunotherapy?
Yeah, as you, I think previously you pointed out, my most important factor here deciding on perioperative is PATS here. I think if you look into the checkmate 816, if patient got PATS here, irrespective whether they have received neoadjuvant immunotherapy or not, if they got PATS here, the 5-year survival corresponds to 95 or 93 something. Means there is nothing to add anything in those patients with into my perspective. If after 3 to 4 cycles of chemoimmunotherapy, if patient got PATS here, 5-year survival was almost 95%. I think there is nothing to add anything in those patients. Almost we are looking like some germ cell tumor or some GTN or something what we are looking at. I think for me, which is driving most into the adjuvant immunotherapy aspect, if patient is affordable, then it's a different scenario. If there are anything, if you ask me where you want to avoid adjuvant immunotherapy, my driving force will be mostly PATSIR1. Second is PDL1. Third is stage. What was the baseline stage of the disease? Whether it is like stage 2 or maybe stage 2, stage 3. If it is stage 3, maybe I try to incline to give like that. If PDL1 is more, then I try to incline to give. If PDL1 is less, then maybe I try to avoid like that. But first driving force will be the paths here. If I got a paths here, then if I am thinking anything to avoid, yes. But in perioperative trials, still, if you got paths here, there is a benefit, but that may be a marginal, not the in the group what you are getting in the patients who are not getting paths here. That's why my take will be if patient is not getting paths here, then I try to incline to give perioperatives.
Okay, sir. Okay. Nice, sir. Nice. Thank you. So these are the treatment outcomes from the perioperative trials. So only so everybody, all the trials have shown EFS benefit, and pembrolizumab has also shown OS benefit also, and so safety. And so are there any specific concerns for the use of perioperative immunotherapy in terms of safety, Dr. Srikanth? Dr. Srikanth? Dr. Vidya Sagar?
I think mostly they are safe. We have been using nivolumab, pembrolizumab for a long time in other indications as well, even in metastatic NSCLC. So I think we are very much pretty comfortable, and the safety profile is pretty much manageable. I don't think we see any adverse events leading to treatment discontinuation or something like that. So, yeah, so I think grade 3, 4 are not that huge. So and they're manageable. That's what I feel.
So there was a recent network meta-analysis also published, which has compared the perioperative immunotherapies. So in the terms of safety, they found that durvalumab had the least risky profile, so least side effect profile. So, but it was a network meta-analysis again. So finally, I think we have already answered this question. That is, we need a multidisciplinary team and patient discussion. And these are the ASCO 2024 guidelines. Thank you so much. Thank you all panelists. We had a wonderful session. Thank you everyone.
Thank you, Dr. Pradeep.
Wonderful moderation, Dr. Pradeep. Thank you.
Thank you. Thank you. So we'll go to our next session, which is by Dr. Rachana Chennamaneni. Yeah. Dr. Rachana Chennamaneni.
Yes. Good evening.
Yeah, Madam is a medical oncologist and assistant professor at Nizam's Institute of Medical Sciences, Hyderabad. So Madam will be speaking on the topic expanding horizons in metastatic EGFR mutated NSCLC with combination therapies. Over to you, Madam.
Yeah. Thank you. Thank you, Dr. Pradeep, for this opportunity. So I'll be speaking about the metastatic EGFR NSCLC. It was a very good panel discussion on the early stage NSCLC, how you're managing and all. So let's move on to the metastatic setting. Sophia, can you share the screen, the PPT?
Yes, ma'am.
Yeah. So I will be discussing about the combination therapies. I won't be talking about osimertinib first line because we are all very well aware and we all have a very good experience with the single agent osimertinib in the first line setting of metastatic NSCLC. So today I'm briefly discussing about the combination therapies which we have available for the first line treatment of metastatic EGFR positive NSCLC. Next, please. So this has been already been discussed extensively, so I don't want to go through that again. Next. And these are the developments which were happening in the EGFR mutant NSCLC space since last 20 years, starting with Geftinib, erlotinib, and the initial combinations which were approved or which were analyzed were erlotinib plus ramucirumab. Then we have the Geftinib plus chemotherapy. Later on came all these newer molecules and the combinations, osimertinib plus chemotherapy or amivantamab plus chemotherapy on progression, or in the first line amivantamab plus lazertinib. So, or first line exon 20 insertion, we have amivantamab plus chemotherapy approved. So these are few combination therapies which have been approved recently in the past couple of years. And these are what changing the treatment management of an EGFR positive NSCLC. Prior to this, every one of us knew that the standard of care would be osimertinib, keeping the finances aside. But now we also have to choose between single agent osimertinib versus these combinations. Next slide. So these are the survival outcomes with the EGFR TKIs which are available. The first one is the progression-free survival. We can see a gradual increase with the change in the generation of the TKI from geftinib to osimertinib, and also the overall survival, which is significantly better with the usage of single agent osimertinib. So moving on to the next slide. Next, please. So the FLORA trial has given us osimertinib, which was the standard of care for more than 5 years. Whatever may be the scenario, whether it is a CNS metastasis or extrathoracic metastasis, patients with any coadded mutations, osimertinib was considered to be the standard of care for the first line management of EGFR mutation positive NSCLC with a median progression-free survival of 18 months and a median overall survival of 38.6 months. This, in the metastatic NSCLC setting, was a very good landmark to attain 18 months of PFS, whereas the prior survivals were only around median survival were around 8 to 10 months with chemotherapy. Next one. So why are we coming to the combination when osimertinib alone was performing so well? It was performing well, but it was not performing to a extent that where we can say the patient is cured, or to compare with ALK positive NSCLC, still the survivals are comparatively lesser with EGFR positive NSCLC. And patients on EGFR osimertinib monotherapy, only few of them remain on therapy after 2 years. Most of them do have a progressive disease. And so we have to improve the outcomes in these patients. And when the second line, whether we can add the combination in the second line and all, we know the performance status of the patient rapidly deteriorates when there is a progressive disease. So whatever we can do, we have to do in the first line setting only. So this is where the need for combinations has started coming up. Next one. So where did the rationale initially start? I was already telling you about the geftinib plus chemotherapy. We have our own study from TMH. Where they have shown that geftinib plus chemotherapy combination has resulted in a significant improvement in progression-free survival, 16 months compared to 8 months with geftinib alone. And we also have the NEJ009 trial, which has also shown a similar significant benefit with the combination of geftinib plus chemotherapy. So this has led the initial step to a combination of a TKI with chemotherapy. And with this, the data for the FLORA2, which is osimertinib plus chemotherapy. Next slide. Next one. So this is a FLORA2 study design. They have included patients more than 18 years with either exon 19 deletion or L858R with a locally advanced or metastatic NSCLC. They did not include the rare mutations or the typical mutations. They included only exon 19 deletion and L858R. Stratification was done based on the EGFR mutation, the performance status, and race of the patients. So the combination was cisplatin or carboplatin based on the investigator's choice, along with pemetrexed, because most of them were adeno or a few were adenosquamous, but very few numbers, followed by maintenance osimertinib plus pemetrexed, which was given 3 weekly again in the maintenance. And the comparator arm was osimertinib, which was given 8 mg, the standard dose. The primary endpoint was the PFS. The secondary endpoints were the PFS2, overall survival, overall response rates, and duration of response, along with the safety. Next slide. Coming to the baseline characteristics, well matched between both the study arm and the control arm. If you see the presence of CNS metastasis, nearly 40% of the patients in both the arm had CNS metastasis at the time of enrollment or the randomization into the trial. Extrathoracic metastasis were also seen in 50% of these patients in both the arms. And if we speak about the EGFR mutation, Exon 19 deletion was seen in 60% and nearly 40% had the L858R mutations. Next slide. So this is the progression-free survival as per the investigator assessment and the blinded independent committee review. So the investigator, it was around 8.8 months benefit with the usage of osimertinib plus chemotherapy compared to osimertinib alone. The median progression-free survival, if you can see at the bottom of the slide, it is 25 months with the combination compared to 16 months with osimertinib. It was 19 months in the FLORA, 18 months in the FLORA trial, almost similar PFS with the monotherapy. And by the independent committee, it is 29.4 months median PFS with the combination compared to 19 months with osimertinib monotherapy. But if you see, the hazard ratio is 0.62, either it was assessed by the investigator or the independent committee. The hazard ratio was 0.6 with a benefit of around 9 months compared to a monotherapy. Combination is doing a significant improvement in the median progression-free survival. Next slide. And if you see the subgroup analysis, majority of the subgroup analysis in the forest plot are favoring the usage of osimertinib plus chemotherapy combination. Non-Chinese Asian, we can see the line causing the confidence interval. That is one subgroup which we have to keep in mind. And the other one is the PS0, which is also slightly crossing the confidence interval, but still the benefit is still favoring the combination of osimertinib plus chemotherapy. Next slide. So what is the other combination option which we have in the first line? We have amivantamab plus lazertinib. Lazertinib is not yet available in India, but maybe in the near future we'll get it. And that's where the comparison of amivantamab plus lazertinib combination or chemotherapy plus osimertinib combination is going to come up. In the Mariposa trial, amivantamab plus lazertinib was compared with osimertinib alone, and there was another arm which was lazertinib alone arm. And the three arms, the baseline characteristics were well balanced. And here also we can see the exon 19 deletion of 60% and L858R in 40% of the patients, and 40% of the patients in this study also had brain metastasis at the time of presentation. And they also included only L858R or exon 19 deletion. And one thing was Mariposa did not allow for crossover when there was a progressive disease. Next slide. The primary endpoint, progression-free survival, as assessed by the independent committee, you can see the hazard ratio of 0.7 with an improvement of 7.1 month in the progression-free survival. The median PFS was 23.7 months with amivantamab plus lazertinib compared to 16.6 months with osimertinib monotherapy. Next slide. So this is a comparison, cross-trial comparison of FLORA-2 versus Mariposa. The PFS and for the independent committee, the benefit with the combination of osimertinib plus chemotherapy compared to osimertinib monotherapy was 9.5 months, whereas in Mariposa it is 7.1 month. Hazard ratio of 0.7 in Mariposa and 0.6 in FLORA-2. Next slide. And if you see the mutation type in the FLORA-2, both the exon 19 deletion and the L858R mutations have performed similarly with the combination. Hazard ratios being 0.6 and 0.63. A consistent PFS benefit across both the subgroups. Next slide. Whereas if we see the forest plot of Mariposa, especially concentrating on the bottom part of this slide on the EGFR mutation subtype, the L858R mutation did not show a significant improvement in progression-free survival when amivantamab plus lazertinib was given compared to osimertinib monotherapy alone. The hazard ratio was 0.78, whereas for exon 19 deletion, the hazard ratio was 0.65. Next slide. Coming to the CNS efficacy also, the FLORA-2 hazard ratios are very impressive. Hazard ratio of 0.47 with the median PFS in the intracranial PFS is 24.9 months compared to 13 months with osimertinib monotherapy. Whereas in Mariposa, the PFS numerically seems to be better, but it is also seems to be better with the monotherapy of osimertinib, 22 months with single agent osimertinib, the median intracranial PFS, and 25.4 months with the combination. Hazard ratio being 0.79, which was not statistically significant. So in the patients with intracranial disease or more prone to develop the disease, you can prefer with the combination of osimertinib plus chemotherapy compared to osimertinib monotherapy when given an option. This subgroup of the patients seem to do better with the combination of chemo plus osimertinib. If we do a cross-trial comparison, unless we do a randomized study, we cannot say that it is the choice of therapy, but yes, preferable to use the combination of osimertinib plus chemotherapy. Next slide. And the complete response rates in the CNS also, there is a higher proportion of patients who had a CR for the CNS disease with the combination of osimertinib plus chemotherapy compared to osimertinib monotherapy alone in the FLORA-2 trial. In the monotherapy, there were only CRs of 16%, whereas 48% of the patients attained a complete response in the combination arm. This is the CNS response rates. Next slide. And TP53, we all know it is bad everywhere, not only in lung, every cancer TP53 seems to be bad and resulting in a poor prognosis. So the patients with the baseline TP53 wild type, the PFS was not reached in both the subgroups, so osimertinib monotherapy or the combination therapy. But for patients with the TP53 altered at the baseline, the hazard ratio was 0.57 with the usage of osimertinib plus chemotherapy compared to osimertinib alone. Next slide. Moving on to the extrathoracic metastasis, presence of liver metastasis, patients with or without liver metastasis have performed better with the usage of osimertinib plus chemotherapy compared to osimertinib alone. Next slide. Similarly, with or without bone metastasis, the combination therapy seems to do better with the presence of bone metastasis or in the absence of bone metastasis. Next slide. And also for the patients who have more than 3 or less than 3 metastatic sites at the baseline, we can see if the patient, if tumor burden is more, there seems to be a better performance of the osimertinib plus chemotherapy compared to osimertinib monotherapy alone. Whereas those patients who have a lower disease burden, both of the arms, there is a slight crossover after a few months of therapy. Though numerically, osimertinib monotherapy seems to be better in this subgroup of patients. But initial few months, if you see, the osimertinib plus chemotherapy arm is over the osimertinib monotherapy alone. But for patients with a high tumor burden, that is more than 3 metastatic sites, osimertinib plus chemo scores over monotherapy of osimertinib. Next slide. And we have an updated overall survival results also of the FLORA-2 trial, a benefit of 9.9 months, that is nearly 10 months benefit with the usage of combination compared to monotherapy, hazard ratio of 0.77 with a p-value of 0.02, which is significant improvement in the median overall survival with the combination therapy. Next slide. So if you see the 3 years overall survival, it is 62% compared to 51%. Next. And at 4 years, it is 49% versus 41%. The curves are still separating with favoring the usage of combination therapy. Next slide. And the subgroup analysis also for the overall survival. Initially, we have seen the PFS forest plot. Now this is the overall survival forest plot. Similar results, most of the subgroups favoring usage of combination, except for the Asian non-Chinese, which we Indians actually fall into. And also, L858R and exon 19, if you see, both of them are crossing the midline, but benefit towards the usage of combination therapy. And CNS metastasis at baseline, patients who have CNS metastasis are performing better with the combination compared to those without a CNS metastasis. Next slide. And this is the overall survival from the Mariposa trial after the maturity of 45%. The overall survival is not reached with the amivantamab plus lazertinib arm, hazard ratio being 0.75. But if we concentrate on the forest plot, you can see patients age more than 65 years and performance status of 0, and patients without brain metastasis and with L858R. These are few subgroups which are not benefiting with the usage of amivantamab plus lazertinib compared to osimertinib, whereas these groups had a benefit with the combination of osimertinib plus chemotherapy. Next slide. Next. So coming to the duration of exposure for the osimertinib plus chemotherapy, though we continue pemetrexed till progression in most of our patients who are not having any targeted therapy available, for patients who are receiving OC plus chemotherapy, pemetrexed was given for an average of around 8 months only. So the chemo-free interval was also longer for these patients who are receiving a combination. You can stop pemetrexed after a few cycles and continue with osimertinib alone. So if you see, pemetrexed was stopped at 8 months, whereas osimertinib was continued up to 30 months also. So you don't need to give indefinite pemetrexed till progression. We can hold it around 8 to 9 cycles and then continue with osimertinib monotherapy alone. And it seems not to affect the survivals. Next slide. And moving on to the first subsequent therapy after FLORA-2, If you see in the combination arm, 69% of the patients received a subsequent therapy after discontinuation, majority receiving chemotherapy, few of them receiving other EGFR targeted therapies. Majority have received a platinum-based chemotherapy in the combination arm on progression also. And if you see the osimertinib monotherapy, nearly 72% of the patients have received platinum-based chemotherapy on progression, which is the standard of care when we didn't have access to amivantamab in most of the countries. Next slide. And safety analysis, since the primary analysis, no new safety signals were identified. The most common adverse events concentrating on grade more than 3 adverse events were anemia, neutropenia, neutrophil count decreased, and most of these are attributed during the chemotherapy period, which have come down after a few cycles of after stopping chemotherapy. Next slide. So this is the slide showing the onset frequency and severity, which were higher during the induction period, that is combination of OC plus chemotherapy. That was the period where they had higher toxicities, especially the hematological toxicities. But as the treatment duration prolonged between 3 to 9 months, the frequency has come down, and over 9 months, the frequency has still further come down with the combination arm. Next slide. So these are the adverse events of special interest in FLORA2 trial. GI disorders, diarrhea is one of the common thing which was seen, but grade 3 diarrhea was less seen in only 7% of the patient. Hematological toxicities were more grade 3. We know neutropenia, anemia usually are grade 3 when the patient comes with those complaints. Skin toxicity was also seen in 66% of the patients, but it was less than grade 3 in most of these patients. Fatigue complained by 1/4 of the patients, but grade 3 fatigue in only 3% of the patients, and paranoia is also seen in few of the patients. Next slide. And if we see the Mariposa safety analysis, paranoia, which we are also facing in our day-to-day practice, majority of the patients are complaining paranoia. Grade 3 paranoia was seen in around 12% of the patients. And we have a skin rash, which was seen in around 17%. This is grade 3 skin rash toxicity, which was seen with usage of Mariposa. Next slide. And infusion reactions are also very well known with the usage of amivantamab. And we also have an Asian expert perspectives on the first-line therapy of EGFR mutant NSCLC, which was published recently in June 2025. Next slide. So the combination regimens like FLORA2 and Mariposa should be considered for all advanced EGFR mutation patients as better treatment options. This was the question which was put for the expert perspectives, which was published recently. And 54% of them have told yes. And those who have told no, there are some subgroups where they want to specifically use this combination, like those with CNS metastasis or L858R mutations, or patients with co-mutations or liver metastasis, patients with higher tumor burden, patients having TP53 mutations, younger patients. So if we see, majority of the experts have preferred the usage of osimertinib plus chemotherapy compared to the Mariposa trial combination for majority of these subgroups, that is the CNS or liver metastasis or co-mutations or L858R mutations. Next slide. And they also identified various differentiators for the FLORA2 and Mariposa. And major point of differentiation was the safety and tolerability. That is one of the main important factor to differentiate between selection of FLORA2 and Mariposa when we are planning to use a combination therapy in the first line setting. Next slide. So if you see the NCCN guideline, preferred is still osimertinib monotherapy, but other preferred regimens are a combination of osimertinib plus chemotherapy or amivantamab plus lazertinib. Both of them are category 1 as per NCCN recommendations. Next slide. So to summarize, the progression-free survival numerically similar with FLORA2 and Mariposa, but the hazard ratios are better with FLORA2 trial. And first-line osimertinib has demonstrated a superior overall survival compared to monotherapy. Median overall survival was around 47.5 months. And it did good in both the L858R and exon 19 deletion, whereas Mariposa was not doing better in the L858R subgroup. And the combination also allowed for a longer chemo-free interval, which would be relief for most of the patients. So these oral survival results from the FLORA2 suggest osimertinib plus chemotherapy can be first-line standard of care, though if not for all patients, the specific subgroup of patients which have bad prognosis like CNS metastasis, TP53 co-mutation, higher disease burden, that is more than 3 sites of metastasis, preferable to use a combination of osimertinib plus chemotherapy, especially in younger patients who can tolerate the combination. Next slide. Thank you.
Thank you so much, ma'am, for the wonderful talk. So if I may ask, from your talk, we can understand that initially our traditional thinking was that chemotherapy didn't have intracranial penetration and probably not effective for brain mets. But here we can see clearly that adding chemotherapy to osimertinib had actually increased the CNS efficacy and response rates also. So any particular reason you want to comment on that, ma'am?
I can't say particular reason that this is doing more better job, because we know chemotherapy doesn't penetrate the brain much. But if we see the subpopulation, 40% had a CNS metastasis. I guess some of them might have also received cranial RT, because in our practice also, we generally tend to give cranial radiation even though we are starting on osimertinib, especially those who are symptomatic or with critical areas of sites, which may allow for better penetration of the chemotherapy. And along with osimertinib, there might be a synergistic action in the brain, which is giving us a better CNS response rates compared to osimertinib monotherapy alone.
Correct. And ma'am, let's
Yes.
say immunotherapy was available, and a patient from Hyderabad comes to you and asks, "No, we would always want a chemo-free regimen." So how would you counsel those patients?
So if the patient is asking for a chemo-free regimen, I would first speak about the toxicities which we are facing with the usage of amivantamab plus lasatinib. I wouldn't directly dwell into the survival cause, because if you see the survivals are not much different. But if we see the tolerance, even with single agent amivantamab which we are using, the infusion reactions, if you are not following the DEXA protocol and if you are not using the cocoon, there's a lot of toxicities which you are facing. We're not finding a single patient who is, I would say, that not even getting a grade 2 toxicity. I guess you also agree with your experience. So that is one thing which I would first speak to the patient. Though it is a chemo-free, the toxicities are almost similar to what we are facing with the chemotherapies, and which are actually manageable with chemotherapy. Your neutropenia you can manage. We all have a good experience with managing neutropenias. But managing paranoia is becoming a difficult task if once it's developed. So first, I would speak about the toxicities rather than speaking about the efficacy there.
Predictable toxicities is OC plus chemo.
Yes, yes.
Thank you so much, ma'am.
Yeah, thank you, Dr. Pradeep.
And we'll go ahead with the next talk, which is by Dr.
So due to an emergency, Dr. Bhavya and Dr. Urmila won't be able to deliver their lectures. I request Pradeep sir to give the key takeaways.
So I think from it is actually a very enlightening discussion for me also. So even I learned a lot of new things today. So from this webinar today, I think the key takeaways we would want to take with us is, if we go backwards, as Dr. Rachana madam has discussed, OC plus chemo is probably the new standard of care for metastatic NSCLC, and also probably we don't have to continue pemetrexed endlessly here. That's what she had discussed. Probably 8 or 9 cycles is good enough, and they won't have an impact on survival. And similarly, coming to the initial talks, we have seen the benefit of consolidation durvalumab and maintenance osimertinib now in locally advanced lung cancer, which has again improved the survival significantly. And also we have understood the role of perioperative immunotherapies also in early stage NSCLC. And now probably irrespective of PD-L1 status, now perioperative immunotherapy will be the standard of care going forward for resectable non-small cell lung cancer. So with this, thank you so much for the opportunity, and thank you all speakers and panelists for a very interesting and enlightening session today.